Thank you, Dr. Yasser, for the introduction. And thank you for Dr. Sridhar and the scientific committee for inviting me to give this talk. I'm also very grateful to Marifa and to our audience who are taken away from their private time to listen to our presentations. I will start to share my screen. Can you see my screen?
Yes, we can see it, Dr. Haitham.
Okay, so basically what I'm trying to introduce an old subject, but with a little bit of a simplified approach to try to take away some of the anxiety that a lot of the pediatricians in the private community and in the government sector sometimes might face when they see a patient who presents to them with a history of syncope. So basically, we'll start out with a description. The syncope is an abrupt and transient and complete loss of consciousness associated with the inability to maintain a postural tone with rapid and spontaneous recovery. The presumed mechanism for syncope, as we know, is cerebral hypoperfusion, and it's actually quite common. Up to 50% of children experience one syncopal attack by the age of 18, and about 15%, according to a study in the Clinical of North America in 1999, about 15% of adolescents experience a syncopal episode during their life. Bimodal age distribution is something to concentrate on. There is a high incidence between the age of 10 and 30, and then again over the age of 65. It comprises about 3% of all pediatric visits. And also, we have to be careful that the majority of time, the syncopal attack in the pediatric population is actually benign. Most of the time, about 80 to 90% of the time, it's vasovagal neurally mediated syncope. And the one thing that will make us actually more concerned if we have recurrent syncope that might result in injury, whether the cause was benign or non-benign. And this will actually produce a degree of functional impairment, which according to a study published in 2003, it's equivalent to the chronic debilitating disorders such as rheumatoid arthritis. So it's something that actually, even though it may not be always as concerning, it might actually become quite debilitating for the patients who have syncope. What we do usually is we look at it in multiple ways. We try to identify the different reasons for it. We have cases where the primary cause is cardiac. It could be structural cardiac abnormality. It could be heat illness, anaphylaxis. The majority of the cases, as we mentioned, is vasovagal. It could be breath holding spells, and it could be conditions that mimic syncope and also leads to sometimes unnecessary workup. I'm going to divide the cases according to what you see on the screen into common causes, which is the vasovagal, neurocardiogenic syncope, breath holding spells, orthostatic hypotension, and the syncope caused by drug or toxin exposure. And also there are more cases that we will concentrate on, which are the potentially life-threatening causes, like primary cardiac and electrical disturbances, structural cardiac abnormality, heat illness, anaphylaxis, and hypoglycemia. So according to a study which was published in 2004 by Masson, he found that 226 children visited the emergency department with syncope. Out of these patients, 80% turned out to be a neurocardiogenic syncope, 9% had neurological disorder, and only 2% had cardiac disorder, which represented only 5 cases out of the total 226. The neurocardiogenic and disease-related syncope were easily identified or suspected by history and physical exam. So it's extremely important to take a very detailed history from the family. And a lot of time you have an idea in your mind what you're dealing with based on the history and the physical exam. About 30% of children with neurocardiogenic syncope were admitted to the hospital. I think most of these cases, the admission was out of anxiety from the family or from the primary physicians managing the patient. The goals of evaluation of the syncope are identifying the high-risk patients with underlying life-threatening cases, or the second step would be to improve the quality of the patient's life and to prevent injury to the patient and to others. As a reference, the two places that you will find a nice summary about syncope diagnosis, evaluation, and management will be in two sources. One of them is the American College of Cardiology, American Heart Association guideline, which was published in 2017, and also the practical instructions for the 2018 European Society of Cardiology guidelines for the diagnosis and management of syncope. Of course, it's a very long document. We wouldn't have enough time to review everything, but I think it would be nice for the audience, if they are interested in more comprehensive review of syncope, to go back to those two executive summaries. We'll start with the common causes. Vasovagal or neurocardiogenic syndrome includes situational syncope, the breath-holding spell, the orthostatic hypotension due to volume depletion, and the drug effects and the toxic exposure. We'll start with the vasovagal, or also known as neurocardiogenic, reflex, neurally mediated, situational, common fainting. Those are several names for the same type of condition. Most common cause of fainting in children and adolescents. It's about 80 to 90% of patients presenting with syncope in the pediatric population. The patient typically describes a prodrome. Usually it's benign. It occurs when part of the nervous system that regulates the heart rate and blood pressure malfunctions in response to certain triggers. If you review this illustration here, you will find that the presumed mechanism for the vasovagal or neurocardiogenic syncope is excessive peripheral venous pooling, which will cause a sudden drop in the peripheral venous return. That will lead the heart to go into hypercontractile state. That will lead to a mechanoreceptors that become typically respond to a situation which is not present because it's responding only to the stretch, and will lead to an increase in afferent neural traffic to the brain. And that actually type of traffic mimics the conditions where there is hypertension, and that will provoke an apparent paradoxical reflex that lead to bradycardia and drop in the peripheral vascular resistance. And that will lead to vasodilation and bradycardia, which would lead to the typical presentation of neurocardiogenic syncope. Usually the triggers are confined warm environment, being exposed to high temperature, standing in line for a long time, or standing in class, or different situations where you have to stand, especially in warm temperatures, feeling hunger, sudden onset of extreme emotion, painful or unpleasant stimulus like trauma, sight of blood, which we've seen a lot of patients, I'm sure all of us in the practice, where the patient present after they've seen blood drawn or seen a blood from a wound or scratch. Dehydration. Usually the prodromal symptoms will include lightheadedness, dizziness, nausea, tunnel vision, feeling flushed and sweating, and will lead, those type of symptoms will lead to syncope. However, in about 1/3 of the patients, usually those are the older adult patients, they may not have any prodrome, and they actually may have a syncopal attack that may lead to physical trauma. The patient education and the patient's family regarding the nature of the disorder is important as the first step of treatment. The predisposing factors need to be avoided, and the patient should also be instructed to lie down at the onset of any prodromal syndrome. Now, the treatment usually is, the first step is to increase fluid and salt intake, which would reduce the frequency of syncope, which was reported in adolescents who increased the fluid intake and took about 2 liters of fluid. According to the study published in 1998, it actually caused a significant decrease in the symptoms and the occurrence of syncope. Daily supplementation with 120 millimole of sodium or about 7 grams of salt for about 8 weeks increased the blood pressure during the tilt table testing and plasma volume compared to placebo, which also led to an improvement in symptoms. And also, according to the study published in the Pacing and Clinical Electrophysiology in 1998, the tilt straining, which meaning standing for 10 to 30 minutes each day against the wall, desensitized the patient to the effect of orthostatic stress. So those are things that will be done as the first step to try to avoid the occurrence of syncope. Now, isometric contractions of the arm and legs and muscles are also known to abort syncopal syndromes. According to the study published in Circulation in 2002, the patients increased their mean blood pressure from 65 to 106 and aborted syncope by crossing their legs and testing their muscles for about and tensing their muscles for about 30 seconds before tilt table testing that would have otherwise provoked them to go into a syncopal attack. Also, in addition, hand gripping and arm tensing is something of good maneuvers to avoid the syncopal symptoms. Now, the managements, I'm sure that people who have dealt with patients with syncope have tried several next step treatment beside the fluid and salt. One of them that is commonly used is beta blocker. However, in the prevention of syncope trial, which is the post trial, they found that it is unreasonable to attempt therapy in older patients to use, using beta blocker and to avoid using it in younger patients. So it may be not unreasonable to use it in older patients, but in younger pediatric population, it has not shown to be as effective as it is in the older population. Fludrocortisone, also in the post-2 randomized clinical trial, it was found to have a marginally insignificant 30% risk reduction in adults with moderately frequent symptoms of syncope. Midodrine was more successful. They found that in 5 randomized trials of this medication in adults and children, it showed a consistent risk reduction of about 43% in syncope recurrence. Also, some studies have looked at the selective serotonin reuptake inhibitor, SSRI, and they found that in several observation studies and 3 small randomized trials, it actually helped in preventing vasodepressor syncope, and the results have been mixed, and there remain a significant uncertainty in terms of the routine use of SSRI, and it's always used as a follow-up step instead of the previous step in case the previous steps were not as successful. So the next type of cases which were included in the common causes of syncope are breath-holding spells. It's common in the patients between the age of 6 months and 24 months, and it's triggered usually by emotional insult, pain, anger, fear. The spell may lead to cyanosis, or the patient may be pallid. The cyanotic variety begins with the breath holding, followed by cyanosis and loss of consciousness. And the pallid spell, there is a loss of consciousness that occurs before the breath holding. There is a brief posturing or tonic-clonic motor activity in some patients, either in the cyanotic or the pallid type of spells. And the clinical course of children with breath holding spell usually is benign. The spells typically start by the age of 5 years, and some children may go on to develop vasovagal syncope, according to a study published in Pediatric in 2001. Orthostatic hypotension, meaning a drop of more than 20 millimeters of mercury in systolic blood pressure, or more than 10 millimeters of mercury drop in diastolic pressure after 3 minutes of standing. It happens usually after volume depletion or during pregnancy, if the patient has anemia, if there is anorexia, or secondary to medication. Patients also who have more significant type of syncope are the patients who have POTS, which is the orthostatic intolerance, characterized by an excessive increase in the heart rate that occurs on standing without arterial hypotension. Usually it's heterogeneous. It's caused by autonomic regulation issue. Partial sympathetic denervation leads to discordant cardiac and vascular sympathetic control, hypovolemia and impairment of the renin-angiotensin-aldosterone system, along with venous abnormalities and baroreflex dysfunction. Usually the diagnosis is number one made by history. In cases where there is some ambiguity about the diagnosis, you do head-up tilt testing, which demonstrates a heart rate of more than 30, increase by more than 30 beats per minute over baseline, or if the heart rate goes above 120 beats per minute. It's usually triggered by dehydration, prolonged bed rest, medications, or other dysautonomias, and those need to be excluded as etiologies. Therapy, volume repletion, fludrocortisone could be used. Alpha-1 agonist or beta-blocking agents also could be used. Now, patients who have drugs and toxins also might lead to syncope, like patients who use barbiturate or tricyclic antidepressant or phenothiazines. Patients also who have sudden loss of consciousness may be exposed to cocaine, alcohol, marijuana, inhalants, or opiates. Now, patients who are more significant, even though they are less frequent and they are more dangerous, if they develop syncope, are the patients with primary cardiac electrical disturbance, like long QT syndrome or Brugada, or short QT syndrome or pre-excitation syndrome. So we'll start with the long QT syndrome. Long QT is either acquired or congenital. Acquired usually is caused by either electrolyte disturbance or drug therapy, and congenital would be the well-known syndromes like Romano-Ward syndrome, which is more common, and it's an autosomal dominant disease, or Jervell-Langen-Nielsen syndrome, which is an autosomal recessive, and it's usually accompanied by sensory neural deafness. The causes of acquired long QT syndrome can also precipitate ventricular arrhythmia in patients with congenital long QT. That's why we always tell families who have patients with congenital long QT to avoid drug therapy that might actually lead to prolongation of the long QT. Normal QTc measurements on a single ECG does not always exclude the possibility of long QT. And the QTc also in response to autonomic state, electrolytes imbalance, and drug may need to also be included in the diagnosis. There are different types of QT prolongation in long QT syndrome. There is long QT syndrome type 1, 2, and 3. Each one of them usually is caused by a genetic abnormality on a specific chromosome, as seen in this slide. And they have also slightly different pattern that you see on the ECG that might lead you to have an idea of what you are dealing with in terms of which type of long QT. And this was according to a study published in Circulation in 2006. Now, there is actually a point system that we like to use in long QT syndrome, and definitive congenital long QT syndrome usually is diagnosed in patients who reach over or equal to 4 points on this scale according to the criteria mentioned in this table. The treatment, beta blocker, is the main treatment for long QT syndrome. Implantable defibrillators are becoming more frequently used. Before they were only used in the older population, but now with the development of smaller AICDs, they are being expanded to be used in younger pediatric populations. There is also restriction of strenuous or competitive exercise, and also, which is very important, avoidance of medications that prolong the QT interval, and family screening is mandatory. Tachyarrhythmia, like Brugada syndrome, it's a sudden cardiac death, could be the first clinical event occurring in those type of patients in as many as 1/3 of patients. Arrhythmic events generally occur between the age of 22 and 65, so it's more in the older population. That's why we don't see it as often in the pediatric population, but it has been reported rarely in patients as young as 3 years of age. The typical ECG, as seen in this slide, is a right bundle branch block with persistent ST segment elevation in lead V1 to V3, and the ECG changes may be transient in some patients. And this is also taken from a study that was published by Coleman in 2007. Brugada syndrome diagnostic ECG findings may be intermittent, and it might change over time or be present only after provocative maneuvers like procainamide infusion. So patients with Brugada syndrome who present with syncope have a 2-year risk sudden cardiac death of approximately 30%, as we mentioned. So implantable defibrillator therapy typically is recommended. Familiar ventricular tachycardia. This is an ECG, which I'm sure that some of you have seen in their practice, especially in the cardiology practice. This is ventricular tachycardia or ventricular fibrillation patients. It happens in childhood or as adolescent who may present with syncope provoked by emotional or physical stress. Several genetic patterns have been described. Arrhythmia typically cannot be induced at electrophysiologic study and can be provoked by exercise testing or IV catecholamine infusion. So a lot of time in those patients, exercise testing is important to provoke this type of arrhythmia to diagnose them. Congenital short QT syndrome is quite a rare disease. According to Shimp, who mentioned his results in 2005, there is an association of sudden cardiac death in patients with congenital short QT syndrome. Syncope or atrial fibrillation and short QT interval have been noted in multiple cases reported, including several children. There are 3 genetic mutations that have been described, and usually the diagnosis is made when corrected. QT interval in these patients have less than 0.3 seconds. Tachyarrhythmia, like supraventricular tachycardia, the unusual presentation of syncope is caused by supraventricular tachycardia. Some of the cases is Wolff-Parkinson-White, where there is a short PR interval or delta wave on the ECG. Patients may present with atrial fibrillation with rapid conduction to the ventricle that leads to syncope. And in these cases, EP study and ablation is the therapy of choice. Bradyarrhythmia, like sinus node dysfunction, congenital AV node block, complete AV block, either surgical or Lyme disease or others, or medication-induced bradyarrhythmia, or hypervagatonia or hypothyroidism. Structural cardiac abnormalities like hypertrophic cardiomyopathy, dilated cardiomyopathy, valvar disease, coronary artery abnormalities, and arrhythmia. We're going to talk briefly about those conditions. Structural heart disease, among the young athletes with sudden death, the majority have unrecognized structural heart lesions. Children with congenital heart disease, including those who have undergone surgical palliation or correction, are also at risk for malignant arrhythmia. In particular, repair defects like tetralogy of Fallot or aortic stenosis and transposition of the great arteries have been associated with sudden cardiac death. The most common cause of sudden death in athlete is hypertrophic cardiomyopathy, which we are describing in this slide. The incidence is about 1 in 500 in the general population. The majority of time, it's an autosomal dominant disorder. It's asymmetric hypertrophy of the left ventricle. It causes syncope with exertion, and there is an annual risk of sudden death in unselected patients with hypertrophic cardiomyopathy of anywhere between 0.6 to 1%. There is discordance between the risk of sudden cardiac death and echocardiographic findings and the presence of symptoms, and syncope is a major risk factors for subsequent cardiac death in hypertrophic cardiomyopathy. So this type of patients who present with syncope are at extremely high risk if they have hypertrophic cardiomyopathy. The etiology of syncope, either it's self-terminating ventricular arrhythmia, it could be supraventricular arrhythmia, it could be outflow tract obstruction, which is severe in the patients who have obstruction in their outflow tract, and this is about 25% of patients with hypertrophic cardiomyopathy. Bradyarrhythmia, decreased blood pressure in response to exercise, or neurocardiogenic syncope. Electrophysiologic testing, it has minimal role in risk stratification, and 12% with hypertrophic cardiomyopathy who received implantable defibrillator received appropriate therapies during the 3 years of follow-up, according to a study published in 2006. Coronary artery abnormality happens in about 1% of the population. It is the second most common cause of sudden death in the young patients. Most children and adolescents with coronary artery anomalies are asymptomatic, And the symptoms usually happens when they are put in a strenuous exercise situation. Syncope or sudden death may be the presenting symptoms, and patients are at most risk when an anomalous coronary artery courses between the aorta and the pulmonary artery trunk, which becomes compressed during exercise, resulting in myocardial ischemia and syncope or sudden death. That's why during echocardiographic testing, it's very crucial when an echo is being done by a cardiologist to look for the course of the coronary arteries, as seen here, whether it's passing between the aorta and the pulmonary artery. Arrhythmogenic right ventricular dysplasia, ventricular tachycardia, and morphological abnormalities of the right ventricle is what comprises this symptom, this syndrome. And it's caused by myocyte replacement by adipose tissue or fibrosis. It happens between the age of 10 to 50 years of age and familial in about 30 to 50% of the cases. Up to 20% of sudden cardiac death in patients happens in the age of less than 35 years old, secondary to arrhythmogenic right ventricular dysplasia. The clinical presentation usually either sudden cardiac death, premature ventricular beats, syncope, or sustained ventricular tachyarrhythmia with left bundle branch block. Syncope is considered an ominous finding. The utility of the electrophysiologic testing in this patient is not firmly established, and also the implantable defibrillators are recommended. Valvar aortic stenosis, they cause sudden death in about 5% of the patients. These patients were almost all older than 10 years and had significant obstruction or aortic regurgitation, according to a study published in 1993. Idiopathic dilated cardiomyopathy causes near syncope or syncope, and it has been reported as the presenting symptoms in about 13% of these patients. Pulmonary hypertension, either idiopathic or Eisenmenger syndrome. These patients may experience syncope with exertional dyspnea, and syncope is an indication of more severe pulmonary hypertension and impaired right ventricular function. Another causes of syncope is heat illness, anaphylaxis, and hypoglycemia. Conditions that may mimic syncope are migraine, conversion disorder, hyperventilation, narcolepsy, and seizure. And the indication for the patient for referral or admission are patients who have syncopal event from which they have completely recovered and that have unremarkable evaluation. Those patients can be followed as outpatient, but you would refer patients who have absence of significant prodrome, if they have palpitations or chest pain, if they have a history in the family of syncope or sudden death, or if they have recurrent episodes. So those four indications are indications for referral in patients with syncope. If you have a patient also with syncope, there are several reasons that might make you obligated to admit them to the hospital if they have evidence of cardiovascular disease, an abnormal ECG with conduction abnormality, if they have a chest pain with syncope, syncope with cyanosis, apnea or bradycardia spells that resolve only with vigorous stimulation, if they have abnormal neurological findings, or if they have an orthostatic hypotension that does not resolve with fluid therapy. We have a few cases here. We have only 2 or 3 minutes. This is a patient who is 14 years of age who passed out while swimming in a meet at school. He said he felt weird before that. He is not on any medication and his family history is unknown. So if you look at this ECG, it's clear that he has long QT syndrome. So he is obligated to have genetic testing, avoid medications that prolong QTC, start beta blocker therapy, and ICD implantation is reasonable in this patient, and activity restriction. Another case is a 17-year-old male who presented with syncope 10 days after he had, for 10 days, he started to have this type of syncopal attack about a month after having mono-like illness, and now he is homebound from school. When we do the ECG and blood pressure measurements, he fits the criteria for POTS, and of course we can follow the guidelines written here about initial conservative treatment and the more aggressive treatment for POTS. This is another case of a patient who is 15-year-old female playing basketball, feel lightheadedness and dizzy, racing hard, has a syncopal attack. negative family history, no medical therapy that she's on, and orthostatic vitals are normal. ECG is showing a typical delta wave. So this patient had probably an SVT with secondary ventricular fast ventricular conduction. And the best treatment is EP study and ablation. And this is a patient that we had in our practice who is 9 years old, had negative family history, had an episode during a competing status at school where she was jumping several times in a row, and she actually passed out. And that episode happened more than one time. She felt clammy and sweaty, and she recovered without any adverse effect, but her ECG was extremely abnormal as seen here. Her MRI and echo were consistent with hypertrophic cardiomyopathy, and the patient recently had an implantable fibrillator. Thank you very much. I'm sorry for having a condensed presentation, but it's a large and long subject, and I am willing to take any questions that the audience may have. Thank you very much.
Thank you very much, Dr. Haitham. It was really an extensive review of a very important topic, and it's unfair to cover it in 30 minutes. I have a quick question for you. What is your take on the readiness and the availability of automated external defibrillators in facilities and like gyms or healthcare or fitness facilities or public places?
I think it's extremely important. This is definitely has to be part of the devices that has to be present and has to be readily available. As we mentioned, that patients, especially young athletes who are quite competitive, they are at high risk of developing syncope secondary to an abnormal cardiac pathology, and having implanted, and having this type of defibrillators definitely could save lives.
Yeah, thank you. So the session time is up.